Welcome to Advanced Patient Care, a podcast series by Vance Thompson Vision. Today's podcast is featuring Cataract Awareness Month. I'm your host, Spencer Morton, and this podcast is here to bring you the latest advancements, cutting-edge research, and practical tips that you can apply to your clinical practice right away. So if you're ready to expand your knowledge, stay ahead of the curve, and elevate your practice, you're in the right place. So I want to start off just by introducing our two panelists. I'm, as I said, your host, Spencer Morton. I'm the surgeon in our South Sioux City office in Nebraska. So I wanted to have each one of our panelists kind of introduce themselves with their name, what their role is, what location they are in, and maybe one fun fact about themselves. So as I said, I'm Spencer Morton, South Sioux City. I am an ophthalmologist doing cataract and glaucoma procedures. And the fun fact about me is that I really enjoy shooting archery, and particularly long distance archery, kind of stretching it out as far as I can do it and have it still be accurate. What about you two? Who wants to start? Sierra.
All right. My name is Sierra Steiner. I'm the optometrist here in Billings, Montana. I get the privilege of working with two surgeons where we do cataracts and glaucoma, corneal procedures, and refractive procedures. And my fun fact is I have 27 first cousins, and that is just on my mom's side.
Whoa. I have zero cousins on my mom's side. My
Wow.
mom is an only child of two only children. So I have just my mom and my grandma now and no one else on that side of the family. So that is a fun fact for me.
Wow. Well, I'm Lauren Swin. I'm the optometrist in Omaha, Nebraska. I work alongside Dr. Brandon Bartman, as well as Lori Preventure. And so we do cataract, refractive, cornea, and glaucoma. Fun fact about me is not super fun. I was born and raised in Lincoln, Nebraska. So I've been born and raised Cornhusker, basically. So that's my fun fact.
Love it. So as a little bit of a preview, in this episode, Dr. Steiner, Dr. Wynn, and I are going to be talking about Cataract Awareness Month. So we've got a couple of talking points just to preview. The first one is kind of patient experience and patient education. We'll get input from Dr. Steiner and Dr. Wynn and myself on some of our pearls and some of the things that we do at Vance Thompson Vision that it might be a little different. Then we'll talk about optimizing outcomes through collaborative care and some of the pre-op, post-op, how ophthalmology and optometry interface and work together. And the third is the future of cataract surgery, just kind of some of the things that we are anticipating and excited about moving forward. So I think we will start with episode 1 leading in here, kind of the patient experience and patient education, talking a little bit about lens discussions, and then again, we'll touch on a little bit of our See and Do program, and again, our back-to-back program. So, we here at Vance Thompson Vision, we recognize that people can go anywhere that they choose for their cataract surgery. And most people in this country live in locations where they have choices, where they have to decide what doctor or what group they would like to see and trust their eyesight with. And typically people end up with a why for why they choose where they go. And, I think a big part of that has to do with reputation of physicians and organizations, as well as, word of mouth. I can't remember the last time that I went and tried a new restaurant because I saw a commercial. It's always because I have a friend or a neighbor or a family member who say, hey, you've got to go try this place out. The food is awesome. And that always carries way more weight than something that you see in print that's put in front of your face. And so I think in order to achieve those things, the things that I always think about is striving for a patient experience that is second to none, where I think we should be able to look ourselves in the mirror at the end of every day and say, patients who come and see us not only feel valued, but know that they're truly cared for, and that the honor is truly ours, not theirs, to see us. I think that we have to have the gratitude as care providers that we are the ones being blessed by the patient, not the other way around. And so I think the way that we can achieve this too through having an experience second to none is by having, the world's best technology and finding ways to suit that technology to the patient's needs, not the other way around, not making the patient's needs fit the technology that we have. And so I think, an experience second to none and outcomes second to none. And our job is to try to achieve both. And so that's kind of how I approach the patient experience. And so getting into the patient education side of things, I'd like to start kind of with some lens discussions. So when we have patients that show up in front of us, they've already met with their optometrist, they're diagnosed with cataracts, they know that they need to have a surgery, and they know that they're going to have a decision to make as far, well, maybe they don't know that they're going to have a decision to make, but they're going to have a decision to make as far as what lens do they want put in their eye, and what do they want that lens to do. And before we can really talk about which lens the patient gets, we have to kind of determine what candidacy they have. Not every patient that walks through our doors is a candidate for every lens that we have available, or is necessarily a good fit for every lens that we have available. So I think that I'll start by asking Dr. Steiner here, what are some of the pre-op tests that you're looking at prior to meeting with the patient and that help you kind of determine the candidacy for certain lens options? And what other factors are you considering when you're deciding who may benefit or not benefit from certain lens choices?
Yeah, we do, I think probably amongst the different Vance Thompson clinics, most of our testing is pretty consistent, but some of the machines will probably look a little different from one location to the next. We always get a corneal scan. We always get a biometry measurement. We always do some sort of back of the eye measurement. So like a macula nerve OCT. On some patients, we get an optos photo as well. Our technicians are incredible at getting those tests in a timely, efficient manner, also explaining to the patient what the test means, which is not an easy feat because it's a lot of tests and a cataract evaluation can take a little while. But our technicians do a really, really good job at gathering all that stuff, making sure we have good quality scans, making sure we have all the information we need in order to be able to match the technology to the patient. So from a workup standpoint, that's kind of what we start with. And then, evaluating all of that stuff to make sure if we're recommending a lens that again, that technology will fit to what their wants and needs might be. And so preoperative workup is important. And then probably just as important or more importantly would be just understanding what the patient wants out of it. So getting to know the patient a little bit during the conversation of how do they use their eyes, how much do they want to wear glasses or not wear glasses afterwards, and then taking all of that stuff into account to make the recommendation and finding that right lens for the patient.
Yeah, Dr. Nguyen, anything that you would add to that?
Yeah, I think also just, ocular history, if they're post-refractive, sometimes we'll grab additional scans like a epithelial thickness map. If especially it's hard to discern if it's a myopic or hyperopic ablation. Glaucoma patients, sometimes we'll go ahead, grab a visual field or a corneal hysteresis, those things too. And definitely, I think the most important aspect is just getting to know the patient. We only have a very short or limited time to discuss and talk to them. And so what's really valuable too, I think, is just the referral notes, just the preoperative notes that we get, because oftentimes there will be a doctor that writes, this patient's very particular, probably is not going to be a good candidate for a multifocal. I might have to pull my hairs out if we do decide a multifocal is going to be the way to go. Or they say, they think they're a good candidate for like a light adjustable lens or something. And so I do think that those notes that are added in the pre-ops are very helpful for us because it gives us more information to go off of.
Yeah, I think to piggyback on that a little bit, sometimes the specifics of the refractive target is really helpful too. There's a section in our referral note that says what's your desired refractive outcome. And if you get a referral note that just says monovision, it's really hard to know, okay, well, which eye is their near eye, which eye is their distance eye, how much anisometropia have they been able to tolerate in the past, how near is their near eye, and a little bit more background is great, especially if you are seeing a patient as a C&do candidate, and you kind of need to know that stuff right away. The other thing that I wanted to circle back on, after agreeing with you, Dr. Wynn, that the referral notes are critical, is how Dr. Steiner had mentioned, oh, and we do a scan of the optic nerve. And some people immediately are like, why are you scanning the optic nerve? I don't have glaucoma. And, I always tell patients glaucoma it can be sneaky. And if you aren't looking for it, you will never find it. And there are oftentimes patients who can sneak through the cracks or be a little bit tricky with their glaucoma diagnosis. And so I think I personally here we get a optic nerve OCT and retinal nerve fiber layer on every cataract evaluation that we do. And it's not because I think everyone has glaucoma, but it is because I think if someone has glaucoma and they come here and I do an intraocular surgery on them and I didn't address their glaucoma or at least give them an opportunity to have it treated, I've done that patient a disservice. And even if I diagnose glaucoma, tell them that they have it, offer a glaucoma procedure at the same time of surgery, and they say, I don't want that, at least they know that they have glaucoma and they're better educated and they leave better served knowing their diagnosis and knowing the things that they need to be looking out for in the future. Anyone else have anything else to add before I move on to the next question?
Yeah, the only other thing I would add in terms of like the preoperative notes or the notes from the referring doctor is any history of prism in the glasses is really helpful and important, because that can be an easy one to miss if it's not a large amount of prism. And the last thing we want to do is put a multifocal lens or an upgraded lens in a patient to get them out of glasses, only for them to be reliant on prism afterwards.
Yes, we've actually had 2 patients now that have shown up with a history of prism and ocular misalignment, and when they were told that they were not a candidate for a premium lens or a multifocal lens because they would still need glasses afterward, we've had 2 patients abort their cataract surgery and instead have strabismus surgery and come back after their strabismus surgery and then have multifocal lenses in and do well. That's a pretty long course, but when people are quite committed, you can still do well with that kind of thing. So I want to move on. A great discussion there, but another big part of, I think, of kind of what we want to achieve to draw people here in particular is we want to be the easiest practice to work with, and we want to be the easiest, most efficient thing for patients to do. And living in the upper and mid Mountain West between Nebraska and Montana here, we do have patients that travel quite a ways, and so we try to minimize the number of trips that they need to come and minimize the amount of time that they're kind of down and out after surgery. And so part of the way that we do that is by our see and do and same day, next day surgery process. And so for people that aren't familiar with that, we are when we're talking about a see and do, we have some front end planning and coordinating that occurs, and then we have a day where we meet the patient and perform surgery on their first eye on the same day, and then we do their second eye the next day. And we also do same day, next day surgery for people that aren't see and do. If they come in for a traditional cataract evaluation, but they decide, I think I want to just do both of these surgeries back to back, we accommodate that for people so that working professionals, people that live far away that want to get on with life and back to action, it helps them do that faster than waiting a week between eyes. So Dr. Wynn, what are the biggest benefits that you've seen for patients that are electing to do the see and do process, and who do you think are the best candidates for this?
I think definitely just working in the Midwest. I mean, there's going to be people that live many, many hours away. And so just giving them the opportunity to not have to make multiple trips back and forth, and just giving them the convenience and ease of mind that they can have this surgery done as quick as possible, like you said, in a timely manner. I think that's going to be kind of key, is just the drive if they don't have drivers. We try to make it easier too by working with, partnering or nearby hotels just to see if they want to stay there versus with family members if they have any nearby. I think that's going to be another key thing. In terms of like who would be like a good candidate, I mean, as long as the referring doctor thinks that they have the information at hand and they can make a decision, I think that's always key. Sometimes there's going to be some patients that need maybe a little bit more time or hand holding. Sometimes they may not be a good candidate just because if they can't make that decision prior or need more information from the doctor itself, sometimes they won't be the ones that will make the decision on the day of their surgery, especially if there's a lot of anxiety or nervousness. So.
Yeah, I think that's some really good points there. And I think, Dr. Steiner, perhaps you could touch in here. Perhaps one of the most important aspects of this discussion is the pertinent negatives. So, who are some of the patients that are not good candidates for a see and do? Because I know that there have been times where we have certain referring docs that just every single referral checks off the see and do if possible, see and do if possible. And I think that it's valuable for people saying, well, who's appropriate to send for a see and do? Is it just that the patient says they want it, or are there times where I shouldn't be doing this? What are some of the instances where you think, man, I think this would be better as a regular referral or regular evaluation?
Yeah, I would say probably the patient that lives 2 blocks down the street is not ideal, mostly just because we try to reserve them for the patients traveling long distances, and we make exceptions to that, of course. But generally, if they can get here easily, we do it in 2 separate visits. A really complex ocular history can be one where we would just say, let's do the evaluation first and then, make a plan for surgery and schedule it at a later date. Really nearsighted or really farsighted patients sometimes will be tricky, and we catch those sometimes on the see and do preoperative calls. We always try to call those patients about a week ahead of time. And so sometimes they've already been scheduled. And as I'm reading through the pre-op note, I see that they're a -12. And so generally we'll still keep them on the schedule as a see and do, but just with the understanding that, hey, we might not have the lens power that you need in stock, especially for every lens implant option. And so if that's the case, then we may postpone it, order that lens and postpone it. Those would be the big ones. I'm sure I missed a few, so you guys chime in.
So I think the thing to add on to that, Dr. Steiner, is anytime where I'm seeing a patient and I'm looking at them and I say, boy, even with great surgery, there's going to be corneal edema here. So if you've got a patient with a really dense lens, a really narrow anterior chamber, Fuchs, things where a bad pseudoexfoliation, as you had mentioned, those are instances where I'm sitting there saying, okay, if everything else checks the box, this is that 90-year-old lady who lives 2 hours away who wants to come in only one time, but she has brown lenses in both eyes and a narrow anterior chamber. And if we do excellent cataract surgery on back-to-back days, she's still going to have corneal edema in both eyes. And what I don't want is this 90-year-old lady to fall down the stairs a day after surgery because she couldn't see well. Right. So I think that as much as we want to help as many people as we can, it does have to be with some diligence there. The last thing I would touch on is probably, bad glaucoma patients that may need an extensive glaucoma procedure that could cause a hyphema or meaningful vision change after their glaucoma procedure. And lastly, people who have uncontrolled dry eye, because it's really, really difficult when you're meeting a patient for the first time, planning to do their surgery an hour later, and their cornea looks like a track meet has just been held on it. And, you're trying to get high quality preoperative measurements that will dictate the quality of your outcome. And if you have, garbage in, you're going to get garbage out. And so I think if you have a patient that really wants advanced technology lenses, but again, has that terrible looking cornea, you're not going to get good scans. And it can get tricky because there's inertia to do the surgery because they're there, they took time off work, they're there to have their surgery, but you have to make sure that it's someone whose ocular surface is amenable to doing a surgery on the day of. But before we move on to episode 2, optimizing outcomes through collaborative care, Dr. Wynn, do you have anything else to add?
Oh, I was gonna say too, patients that have had recent retinal surgery, if they've had any sort of like silicone or oil in the eye, and it's gonna obscure the biometry, I mean, that's definitely something we want to wait until the retinal specialist has been able to take that bubble out just to make the scans more accurate.
Yeah, that's
Sometimes the surgery before with a bubble, that's pretty minimal, but probably want to hold off on that one.
yeah. I think that the timing and tempo of when you pursue surgery is important after already having had one surgery. So
So
I think. Go ahead.
previous RK patients can be really tricky for a see and do as well, just because they require so much conversation, and generally having at least a couple sets of measurements on them is helpful. And
Yeah.
so that's another one that it's not a hard rule for us, but we usually try to talk them into doing it in separate visits.
Yeah, I think any kind of previous refractive surgery, especially incisional refractive surgery, warrants at least an orange flag of a pause, and let's make sure that this is someone that absolutely needs this, and then you pursue.